So we're finding the positives of being able to meet virtually is we've had some great people who are being very kind to us and coming to support us, which is fantastic. We are 33 countries, Julia, and we have almost 200 people in the network, many of whom that are very active across 7 working groups. So all with kind of not necessarily distinct identities, but core tasks, as Inge keeps reminding us that we have to keep the memorandum and the deliverables in sight.
Yes.
And anything else is extra and a bonus point. So like
exactly. Exactly.
John, I think we are ready now, and Stefan has started the recording.
Great, thank you. Yeah. Thanks, Stefan. So do you have host, Inge?
Yes, I have host. Yeah.
Fantastic, that's great. So Julie, if it's okay with you, we will start. We have been waiting with bated breath for your presentation today, so thank you again for getting up at a completely different time zone and agreeing to share your time and your expertise with us. But for those of the researchers in the network who are not yet familiar with your work and who will be quite soon, just to say that Julia Seng is a nurse midwife and a professor of nursing obstetrics and women's health at the University of Michigan, and that's in the Midwest of the United States. Julia is also an ally in the work to make birth a positive experience for all, and including the staff, which is quite important given that we're focusing a little bit on interactions with caregivers and how they may have a role in terms of a traumatic experience. And Julia's research focuses on how childhood maltreatment and post-traumatic stress affect childbearing, and essentially what maternity care teams can do by way of responding and optimizing that. She's also a co-developer of the frontline intervention for PTSD that fits with maternity care systems. And currently, Julia is conducting some implementation projects with systems in Blackpool in England, in Buffalo, New York, and in Chicago in Illinois. So Julia, we are really looking forward to hearing your presentation. And if it's okay with you, we'll have questions at the end or in the chat box. And again, it's just to remind everybody, also on this link, there is we don't have to change to the next one, which says networking. So it's really for an opportunity for us to meet with Julia, and for Julia also to get to hear what we're doing across our different countries and our little pan-European group that we have here today. So Julia, if you're okay to share your screen and start, or that would be great. Thanks a million.
It is wonderful to be with you all here today and to see familiar names on the screen and people that I've gotten to spend a little bit of time with and talk about things along the way. So it feels very nice to be among you. I also am wondering real quickly, maybe before I start sharing, if you could use your hand or just wave. I'm curious how many of you are mental health professionals and how many of you are midwives or maternity team professionals. So how many are midwives or on that side of the world? Okay. And how many are therapists or mental health providers? Okay, awesome. Knowledge base, and it means also that I end up having a talk where I just have to put everything out there and talk from both the mental health and obstetric side of things. Usually I'm talking to one or the other, but this is a great integration of both. So my goal also is to kind of talk fast and get to the end and tell a coherent audience, and I think that your questions may be more interesting than the information I'm going to present here. And so let me go kind of quick, but do feel free to put things in the chat.
Joan, do you think she lost her connection?
I would say so. I would imagine, hopefully we can just hold on and she'll be back. There was a little bit of freezing first, which is always a bad sign, isn't it?
Yeah. Yes, there you are again, Julia.
I'm very sorry that I lost you there, but we'll just keep on going.
Yep.
Can you see the slides now?
Yes.
Yes.
Okay, and also before I go much further, I want to acknowledge really the huge number of people who participated in growing a program of research over time, especially my closest collaborator for more than 20 years now, Mickey Sperlich, who is a certified professional midwife and a social worker and infant mental health specialist, and she sends her greetings to you today. And then just to remind folks that this is really interdisciplinary work, that I collaborate with midwives, statisticians, psychiatrists, some Aussies and people from the UK, and that many students have been involved and women have shared their stories over 2 decades now as we go forward with this work. And today I want to talk about both PTSD and PTSD following childbirth and the continuum of care, which I'm going to illustrate some things from our implementation work with the intervention that we're working on right now. And I want to share some things that I see coming down the road at us, just in case they haven't come your way yet. So I was making this slide to think about all of the types of PTSD that we're dealing with here. And I loved it because after I looked at it, I couldn't even read it. It looks like gibberish. But basically, we actually are talking about many types of PTSD. And so I'm going to frame those by showing this slide, which is one of my favorite cartoons, where the standpoint that you occupy does affect what of the phenomena you are able to see. So midwives, home visitors, psychotherapists, they may all be perceiving this phenomena from a different perspective. And the lens that you're looking through does make a difference. So today, what I'm hoping to do is just put the vocabulary out there, and then I'm going to try to use it carefully. But basically, I think a lot of times we just toss out PTSD, and that's absolutely fine, shortcut for what we're talking about. But also we could often choose to nuance that a little bit. So our standpoint in time matters. As a midwife, I start in the perinatal period. So I tend to notice PTSD that the women already bring into pregnancy with them. And my main goal around birth is to prevent re-traumatization and postpartum PTSD. Other people join in the postnatal period, so they're seeing postpartum PTSD or postpartum post-traumatic stress symptoms. And what they're seeing could be from the birth, and often that's what's, drawing attention at that time, or it could be pre-existing as well. So some of the women were healthy before birth, but some of them already had something that was going on. So then the next question is which type of PTSD, because there's more than one really. There's what I call the majority type, and then the minority type, which is complex PTSD or PTSD dissociative subtype, which affects about 14% of cases of PTSD worldwide. And actually in our data, it came out as exactly 14% among the pregnant women as well. So classic PTSD that looks more like an anxiety disorder and has elements of anger or avoidance or hyperreactivity is easier to see. It's more visible, their behaviors or reactions with it. The dissociative subtype, however, can be nearly invisible because it is a muting of reaction. So it's hard to see, but it may convey higher risk for women who are going to become parents. How much PTSD? We just throw out the term PTSD without paying too much attention that it does have the word disorder in it, which tends to mean that it's at a diagnostic level. I tend to use that term if clients are okay with that term. Some clients are not, and they prefer to use the term PTSS. So to take the disorder out of it. And then when did it start? This is the key piece that I think affects our work. Did the woman have PTSD already? Was it pre-existing? Or is a childbearing event or experience the index trauma? So was she, perfectly healthy before the birth, and now she's in an acute phase of new PTSD? Or was it an old problem that was chronic and it's now exacerbated? So the one reason that I want to talk about PTSD in particular, the dissociative subtype, is because some of the work that I've gotten to do has been biologically based. And our hypothesis was that it would be women with PTSD who would be different from resilient trauma-exposed women or from healthy controls. But in fact, that hypothesis was not very well supported. It was the women who had complex PTSD or the dissociative subtype who have biological differences. So in this slide, this is a study where we had about 5,000 cortisol samples from women from early pregnancy all the way across to 6 weeks postpartum. And you can see in the yellow circle there that the red line is the women who have complex PTSD from childhood maltreatment, and that in early gestation, their fetus is essentially swimming in the stress hormone cortisol. And so we need much more research to replicate this finding and to see what the outcomes look like for the child. But we know from Dutch and English research that when there is crisis for a woman, famine or extreme stress like wartime, that these levels can be very high and they can result in chronic health problems for the offspring through the developmental origins of health and disease. And so this has been shown like in the ALSPEC work in the UK. So here we see it, but not with PTSD per se. We see it with the dissociative subtype. And then here's the last biological slide that I'll show you. This is a smaller study looking at oxytocin, which is just much harder to measure. And again, we see that the women who have the dissociative subtype, the purple line, that their oxytocin levels are vastly above normal. The normal levels, the healthy controls are the blue line, and the classic PTSD without the dissociative subtype is the red line. So they're down around 150-ish, 100 to 150 within the normal range for oxytocin. But the women with the dissociative subtype are up between 400 and 600. So a vast overshoot of oxytocin. And again, we don't know what meaning this has or how it plays out so much in behaviors or in complications, but oxytocin is very important to childbearing, to parturition, lactation, and to the bonding and long-term attachment relationship with the infant. So this is concerning and needs more research. So the big question is, I'm talking about two types of PTSD, right? PTSD from something that the woman brings into pregnancy, and then PTSD from the birth. And what are those proportions? There have been quite a few studies. When you look at samples that have kind of a normal community sample, what you find is that about 1/3 to 1/2 of women report that their birth was traumatic to them, either because of an OB event or because of care that they perceived as poor, either incompetent or uncaring. And the rate of actually getting post-traumatic stress from that birth experience, being fully symptomatic, is around 6%. And that's true in work like Susan Ayer's early work, And it was exactly the same rates as she found in England, I found in the Midwest. So basically, overall post-birth PTSD rate of around 6%. In our data, though, we knew how much PTSD women had pre-birth. And so we know that about 3 out of 4 women who meet diagnostic criteria in the postpartum period actually had PTSD already from something else that was probably salient. And so we have to think about them as being especially vulnerable to birth trauma, because it's probably a re-traumatization. The way that we manage birth is something that they're particularly vulnerable to. So another way to think of this is that the 2 columns are like yes, no. Did the woman have PTSD already? And then the 2 rows are, was her childbirth experience traumatic? And then again, you see the 4.5% rate of PTSD in those who already had PTSD, 1.5 in those for whom childbearing was a new trauma, new PTSD. And I really like that square in the 2x2 table of the happy women, where, you know, neither pre-existing nor traumatic birth. And we want to get as many people in that block as possible. So basically, whichever standpoint you're occupying, postpartum care or pregnancy care, we have the same aims. We are trying to prevent birth trauma, whether it's a new trauma or a re-traumatization. And trauma-informed care, which is a complex paradigm to put into place, is certainly a main modality that we can rest into to accomplish this work. So what do we know about prenatal PTSD? The main thing that I think the literature has shown, whether it's been qualitative literature or quantitative literature, is that there are many triggers in pregnancy that can make birth a traumatic experience for women as a re-traumatization. So salient trauma histories from our study, we measured 30 trauma histories, but car accidents or combat experience, house fires, these were not activated during pregnancy, these old traumas. The things that caused women to be symptomatic at a diagnosable level were a history of child maltreatment, which affects 1 in 5, a history of sexual trauma, which affects 1 in 6 in our study. And when you overlap those in a Venn diagram, you basically come up with about 1/3 of women who are bringing one of those salient traumas in. We also found that previous reproductive loss could lead to full symptomatology in pregnancy and previous medical trauma. And we know from other studies that, of course, previous traumatic birth could lead a woman to be fully symptomatic in pregnancy as well. But we don't have that information from our data because all our women were primips. So basically, these are salient histories. And why are they salient? They're salient because there are triggers that occur during pregnancy itself, prenatal care, birth, and the postpartum period that remind the woman of the trauma that she experienced before pregnancy. So triggers have been characterized throughout the literature, especially in qualitative studies. So it doesn't take much imagination to know that there could be inescapable bodily experience in pregnancy, vulnerability in a caregiver relationship where you're dependent and going to be in pain and have intrusive contact. As our friends, the Swedes, call it, it's almost like pre-traumatic stress disorder, because once you know you're pregnant, you know the baby's going to have to come out. And so you have a trigger hanging over you for 9 months. And also we know that people who bring a maltreatment history into pregnancy with them have significant worries about parenting and protecting their child within a family system that had maltreatment occurring. So basically, we call the triggers of pregnancy the 4 Ps. And these are pregnancy, prenatal care, parturition, a fancy word for labor and birth because we needed one that starts with a P, and parenting. So the 4 Ps are all things that can cause a woman who has pre-existing PTSD to be symptomatic. In terms of the rates, from pregnant samples, kind of normal community samples, we know that the lifetime prevalence of PTSD is around 20%, and that's the lifetime prevalence, so having ever been fully symptomatic. That's the rate of females in the general population in the United States, so that's not very different in pregnancy. The rate of PTSD that's currently diagnosable in pregnancy is around 8% in this normal community sample. That's twice the general rate among women in the US, which is 4.6%. And that's probably just because of all those triggers that we talked about, that they're more activated and more likely to meet diagnostic criteria during pregnancy. That 8% rate, though, the thing that's really important is to take that with a grain of salt. That was kind of a normal clinical sample. But when you get into high risk settings or low resource settings, highly traumatized populations, the rates are considerably higher than that. So an example would be the work out of Atlanta. Grady Memorial Hospital in Atlanta has a terrific group of PTSD geneticists, and they study PTSD in downtown Atlanta in a hospital where most of the women are African American. So, suffering real inequity in their health status, including PTSD. And there, the rate of PTSD in pregnancy is around 30%. So you just have to know your population there. Another really important thing is that in our work, the rate of perinatal depression is about what it is in most other studies, but most studies don't seem to look at PTSD and depression together in pregnancy. And when we did that, 84% of the depression cases also had full or partial PTSD and some sort of trauma history. So we like to use the iceberg metaphor to say that depression is probably what we've been seeing so far, but the PTSD and trauma is the part of it that's been under the surface of the water and undetected. We also know that women with PTSD use substances or maladaptive coping to self-medicate for noxious PTSD symptoms. So the overeating or obesity that we see in pregnancy, sleep problems, unsafe sex, those risk factors that we have prenatal care to help cope with probably have roots in PTSD. And also we know that people with PTSD have central pain sensitization. So they may also have some maladaptive coping or simply more interactions around the aches and pains of pregnancy. And, it's not all in their head, it's all in their brains. They actually do have more pain than other women. So there's a lot of trouble that we see in prenatal care that has its roots in PTSD. And I want to just give you an example again of why it's PTSD and not necessarily trauma per se that we need to pay attention to, because setting matters. Ann Arbor, which, as I was saying before, is a university city, very affluent, highly educated population, high resource clients, and Detroit, a very low resource setting with majority African American women, the rates of maltreatment and sexual trauma and the rates of lifetime PTSD are very similar. But the rate of having PTSD in pregnancy is very different. In Ann Arbor, it's 3.9%. So it's actually below the US average rate for women. In Detroit, it was 14%. And it doesn't surprise us because in Detroit, the age of first pregnancy was younger, so they've had less time for recovery. They've had a total of twice as many high magnitude trauma exposures. Their most recent one was much more recent than in Ann Arbor. They've had less mental health treatment, and they continue to live in a context of high crime rate and a suboptimal built environment. So more accidents, more injuries that happen. And so it's not surprising that they have higher rates of PTSD, but this means that wherever you are, how vital it is to deal with the prenatal PTSD may differ. So I know that you're quite familiar with PTSD, but I want to just emphasize here some of the key things, which in the column on the right, those are the new DSM-5 symptom clusters, which now include negative cognitions and mood. So it's like depression has been sort of moved into the PTSD diagnosis. But functional neuroimaging studies that laid groundwork for DSM-5 showed very clearly that the hippocampus and the amygdala are very overactivated. So they respond to fear as though it were the danger was happening now. And those reactions are not modulated by the thinking part of the brain, the prefrontal cortex. Whereas in depression, the out-of-body experience that people can report, or the feeling that the overwhelming thing that's happening to them is unreal or like a movie, that is sort of a self-anesthesia. It's an escape that can be pulled into use when there is no escape. This form of post-traumatic reaction happens almost always among people whose maltreatment was in childhood. It's a pre-verbal type of coping with overwhelm. And the functional neuroimaging shows that it is an over-modulation of fear responses. So it's a shutting down of the fear response. We're more likely to see it as a freeze or a surrender or faint response. So these are very important because it's easier to see the classic PTSD than it is to see the dissociative response. And this slide is from a study that we did of dissociation in labor. And what you can see there is that the vast majority of women had not a single symptom of dissociation. It's not a common response in labor. But there are some women who had quite high levels of symptomatology. And so what we found in that study was that those who already dissociated in early pregnancy, so it's a coping that they've used for a long time, they are more likely to deploy dissociative coping in labor when they get overwhelmed. So think of it as a trait that they already have. And in labor, you may be witnessing the state of paratraumatic coping with dissociation. Now, this can happen to anybody. Most of the research on paratraumatic dissociation, or sort of live dissociation, has been done in emergency departments with gunshot wound and stabbing victims or motor vehicle accident victims. Any adult who encounters an overwhelming trauma could dissociate. But what you can see from this slide is that birth doesn't really seem to rise to that level for most women, that it's the women who have the trauma that they're bringing into pregnancy with them who are the most likely to dissociate in labor. So the trait predisposes and the state of overwhelm precipitates a dissociative reaction. And then we know from our prospective data that the dissociation in labor was a risk for bonding problems and potentially a risk for maltreating the infant as well. So we draw the picture of the phenomena as the cycles of what the mother brings into pregnancy with her. I don't know if you can see my arrow here, whoops. But what the mother brings into his pregnancy with her as pre-existing PTSD and depression, and then her pregnancy PTSD, the birth experience, which could be traumatic or could have an adverse outcome, leading to postpartum depression and PTSD and bonding problems, which then leads to an impaired dyadic relationship and goes on to put the child at risk for maltreatment or psychiatric vulnerability, and you've got the cycle going around again. And that this may be happening in a context where there's an abusive partner or a family of origin member who is problematic. The thing I want to point out to you here that our data showed us is very interesting and really merits a specific study is that we have the habit of mind that postpartum mental health disorders in the mom lead to bonding problems. But our data showed that the women already had relationship problems where they said that they felt detached from other people. And that is a part of PTSD symptomatology. It's a part of depression. And then they had bonding problems. And it's possible that the bonding problems are actually making the moms depressed, as well as the other way around. So I think that this is an important thing to study next, because it might get us to where we are able to focus much more on the dyadic relationship from the beginning as another means to prevent postpartum mental health problems. So I want to go now into what can we do about this? And the thing that's really important is that for depression, we've built up a system over the last decade where, by and large, we're able to have the obstetric team refer women with depressive symptoms to mental health services. Sometimes they're tailored to the perinatal period. Sometimes they're even co-located. So that is a very good advance, but for PTSD, that is not sufficient. And the reason for that is that the maternity care providers themselves may be witnessing, or they may actually be causing, triggers to PTSD. So they have to learn how to try to avoid that, or how to repair it at the bedside if it has happened. So we need to go into this trauma-informed continuum of care and build it so that referral is one of the options, but it's not the only option. This image is probably familiar to many of you. It's the World Health Organization's idea of a tiered system of universal, targeted, and specialist interventions. And here we've just mocked it up in relation to trauma-informed care. So universal is a trauma-informed approach, essentially changing habits of mind to ask what's happened to you instead of what's wrong with you, and to take into account the 1 in 5 women who have this history more in high-risk settings even. And then going to the top, that's the system we already have. Ideally, it's not complete, but where we would be able to refer to a psychotherapist or psychiatrist for medication or psychotherapy to be able to treat the post-traumatic stress disorder or other sequelae of the trauma. With PTSD treatment, that is trauma focused. All of the evidence-based psychotherapies for PTSD do involve talking about the trauma as the way to actually cure the symptoms for that. What's interesting to us, and what I want to emphasize, is the middle tier, tier 2, which is targeted interventions. In this case, I call those trauma-specific interventions. And for midwives especially, I divide them into 2 categories. Practices, which might be developed ad hoc in collaboration with a unique client. It might be idiosyncratic to the client, but examples might be having a conversation about what triggers them and making some strategies to avoid those triggers. Or perhaps developing a special form that's like a birth plan where the woman could write her triggers down or talk about what she needs under those circumstances. And the second category is programs. And so these would be sort of manualized, fully developed resources that could be offered to a single client or to groups of clients. And for those who self-identify as being trauma survivors. And these could be delivered by frontline clinicians. The universal approach essentially involves the whole maternity care team, from the office assistants to the nurses in labor and delivery, everybody. And the tier 2 involves clinicians, but potentially anyone who works providing direct care on the maternity team. So essentially, for those of you who don't get to keep your pulse on the treatment guidelines for PTSD, they're hot off the press right now. They came out in late 2020. by both international organizations, ISSTD and ISTSS. And there was really, nearly complete agreement on the recommendations across both of those manuals. So essentially, there are strong recommendations for the efficacy and effectiveness of EMDR, eye movement desensitization and reprocessing, 3 forms of CBT, prolonged exposure, cognitive processing therapy, and cognitive therapy. Those sound very much alike, but they're manualized and they have slight theoretical differences and implementation differences. And then my personal favorite, and I know there's some people in the audience today who also are strong proponents of narrative exposure therapy, which is, I think, particularly vital for midwives to become familiar with and to consider taking up and studying, because narratives are really important. Telling our birth stories are normal, and it's a normal part of that 4th trimester process. And so it dovetails very well with telling your trauma story. And also because NET is fully manualized and has been delivered by non-therapists around the world, including lay people or community health workers. So it would be within the scope of practice of nurses and midwives to take the training for NET and to be able to deliver it. So specialist midwives in particular would be able to do this very well. The thing that's important here, though, is that this evidence base is very, very strong, but there have not been RCTs or studies of safety with pregnant women. I shouldn't say there haven't been any, but they're very scant. So, this is something that a network like your group could try to figure out a way to be able to do reasonable studies of these modalities. Sorry, let me find my place again. I might need that second cup of coffee. Okay. So then also pharmacology treatment has only a low effect on PTSD. So it is not considered a cure for PTSD, but it is often used as an adjunct to psychotherapy to make the challenges of psychotherapy more tolerable, or as an alternative when people are not able or willing to do psychotherapy. So you can see here that SSRIs and SNRIs have 4 medications that do get the recommendation for use, but as a low effect recommendation. And then a paper came out just at the very end of 2020 by Thompson and Sharma. It's an expert opinion paper only, but it encourages sertraline as having the best profile for pregnancy and breastfeeding. And you can recognize that sertraline is used a lot for depression in pregnancy, so it has longstanding evidence for depression. It hasn't actually had pregnancy effectiveness study for PTSD. So that's another piece of low-hanging research fruit. So what I want to go on to now is the stuff that's squarely in our wheelhouse, though, at tier 2, the ad hoc provider-client collaboration that could happen to create practices that would be trauma-specific, and also programs. So far, the ground is wide open to be creating programs. And I know that this group has been working here and there about testing interventions for PTSD following childbirth, including debriefing and short education interventions, and that psychotherapy is getting used. So that is great. In pregnancy, there has been much less that's been done. Really, there are 2 that have any evidence base at all. So the first one is our Survivor Mom's Companion that I'll tell you more about, but it has only had pilot and implementation studies completed. We have not been able to get funding for an RCT, although like Julio Lineweber, who's here, worked with the Australians, and we put in Australian government grants, like a decade ago for this. And all of our grants that we've put in, including in the United States, They've all been looked upon favorably and they have scored, but none of them has ever funded. So that is a real challenge. And, you know, I'm pretty political, and there's part of me that says it's because we want doulas and nurses to be able to deliver this front line. It's not a device, it's not a drug, it's not going to be profitable, right? And so, and some people also just think that education isn't an intervention, and so we don't need to study it. But I do think we need to establish safety, because, you know, that's not a foregone conclusion that even education is benign for this population. So we have survivor moms. We have Seeking Safety, which is a very well-established PTSD psychoeducation program, but it is for dual diagnosis. It addresses unsafe coping behaviors, so essentially substance abuse and PTSD in tandem. But it has been moved in one study into the prenatal setting. It's been done as group, or done with group prenatal care by community health workers, and the results were good for that. I think the big difference between these two is the second one's focus on substance abuse. So it's not available for as many people. And also that Seeking Safety was not intended for pregnancy, and Survivor Moms was written by midwives, and it is very specific to pregnancy. And then the third thing that I would call an intervention has not had outcomes research done on it, but it's a website in the UK created by Elsa Montgomery and the Survivors Trust. And it's based on qualitative research. And it's a website that has a series of videos about pregnancy, birth, and parenting after child sexual abuse in particular. So the other things I wanted to point out to you is that When Survivors Give Birth is probably a book that most of you are familiar with. It's written by Simkin and Klaus. It was from 2004, and it gets used for training a lot of professionals, or a lot of professionals seek it out as a way to improve their labor management skills with child sexual abuse survivors. But I recently found out that it's out of print. And I'm not sure, but Penny didn't answer my emails. And so I'm thinking she may be retiring. And so this is another ripe area. This book's 20 years old. If somebody wants to write a new one about managing labor that would get used by young professionals just learning, it is a great niche. Somebody should definitely fill that. And then also there are more studies being done on NICU moms about the PTSD from having a child who ends up in the NICU. And so we might be able to build on those as well. One other thing I wanted to say is that from the literature in general, especially postpartum literature, there has been the realization that when the intervention is dyadic, when it brings the infant or the infant to be into the intervention, the results appear to be given a bit of a boost or strengthened. I think that's really important to the moms. So that's another thing I think that's a distinction between Seeking Safety, which happens in a prenatal clinic, but it's not focused on an infant, versus Survivor Moms, where it's all about the fact that you're going to be parenting an infant now, and you want to keep that infant safe and give them the strongest start. So keep that in mind if you go developing something, to be sure to pull the infant into it. One other thing is that Western psychotherapy has been the dominant paradigm for addressing PTSD, but many things are happening that are indicating that it's certainly not the only way to address PTSD. And so we wrote this article suggesting that interventions can happen at multiple eco-social levels. And so I would really strongly encourage you to think in this way as well. At the societal level, I think of it as political activism, or making women aware that they're part of a large group. I think Me Too has paved the way for us to do this in some ways. So it's a movement instead of an individual psychotherapy. And then also at the community organizational level, there could be survivor mom groups or things that are in the community where women who already have children can help women who are pregnant, that type of social intervention. as well as the interpersonal, which could happen in psychotherapy or could happen with a doula, and then individual, where self-regulation is probably a very important topic, especially as a baby is on the way. So think creatively and think broadly about what types of interventions you can need, and especially keeping that tiered intervention in mind, where only some people need the top tier with a specialist, but a lot of people could do the trauma specific that's targeted and frontline, and often is education and support. So just to recap, trauma-informed care is the universal part, and it's not enough. We also need trauma-specific interventions and trauma-focused treatment. So we need to ask ourselves, are we going to build this based on awareness of how many people in the population have this? So based on epidemiology, or based on people being able to self-identify that they have an unmet need, or based on distress, impairment, and diagnosis. And where does the woman fit? What does she need with that? I want to go now to putting some flesh on the bones of that, because one of the things that we've learned is that we thought the logical place to start would be with the universal and like implementing screening. And we have learned over time that we don't get anywhere after that. That in fact, people on the ground won't screen for trauma history and PTSD unless they have something to offer, which was a no-brainer realization on our part when we thought about it. So we have given up the idea of being tidy and going in order. And now we're promoting dropping an intervention right into the middle, because if they have something to offer, then they will start screening and changing their habits of mind, because they'll begin to see how many survivors they have in their practice who are interested in having programming for themselves. And also, you can't really offer something frontline without having specialists available to take referrals for people who need more. So it helps to cultivate the network and to encourage the providers to get trained on evidence-based PTSD interventions. So this is a more disruptive model. Instead of starting at the shore and swimming out, we're just suggesting to dive into the middle and create the whole system when people get excited about what they could offer to women. And to that end, we have worked on the Survivor Mom's Companion, and that has been our sort of disruptive intervention. When we were creating it, we basically wanted to integrate mental health care for PTSD into the obstetric system. Depression, anxiety, perinatal stress, intimate partner violence, substance use, and smoking were already visible on the surface. It was the tree. People were responding to it, but they were not perceiving the roots under the ground, which was this cycle of intergenerational familial abuse and neglect. In the United States, the very big concern about historical trauma against Indigenous people and African people, and certainly not perceiving the PTSD symptoms. So we started working with, the healthcare providers to see about intervening. And we actually started at the top, trying to create an intervention that midwives, nurses, and potentially social workers in particular could use. But what we found through implementation projects was that there were others who had less education, who wanted to deliver it, and in fact were very good at delivering it and are much more cost effective. So these days we're also working with doulas, who are paraprofessionals in the United States, home visitors who might be nurses, but often are also paraprofessionals. They're community health workers or outreach workers. And we did that in Buffalo, New York, in a very low resource setting, and it went great. And now we're working on the west side of Chicago in a very low resource setting, almost 100% minority, 30% African American and 70% Latinas in this community. And we're using parent advocates. So people who are used to working in the community to improve people's lives, but they are not paid workers, and they have very low levels of education. So what women told us they wanted, and I think that much of this would still be true if people went forward creating new interventions. They want to know they're not the only one. So basically taboo breaking. They want to be able to find other survivor moms. When they find out that there's 1 in 20, they're like, well, how come I never met one? And it's because, women still feel like they have to act like they're having this glow in pregnancy, not like they're having insomnia and nightmares because they have so many anxieties and worries. They want to know that they are not alone. And when they said that, what they mean is they want alliances to get through this. So whether it's with healthcare providers, whether it's with childcare providers, or potentially just support groups of peers, they want help to get through this. The women who bring maltreatment PTSD into pregnancy with them, we know from their data that they have much less social support than others. They have less satisfaction in their partner relationship. They're much less likely to actually be married, though not less likely to be co-parenting. And often they have ruptured relationships or toxic relationships with their family of origin. And so they really need even basic social support to be built up during this time. They were really happy to know there's a name for it. And when we started doing this research, people didn't even know that PTSD happened to women. Like, we had to start some of our early articles by explaining what PTSD was and that it wasn't just for combat veterans. So I think that has changed. But what the trouble is that women don't know that what they experience is symptoms of a disorder that can be treated. They think it's character flaws or personality on their part. And so having a name for it opened up all sorts of possibilities for them. They wanted to know that there is a treatment, although they're not necessarily going to approach treatment during pregnancy. They like to think that they could approach it someday if they needed it. They want information and skills to use during the childbearing and early parenting period, and they want to access it via the maternity system. They would much rather talk about this stuff with their midwife or with a health visitor than go to a psychiatrist or a mental health setting for it. And we co-created Survivor Moms by talking to a lot of people. So in that book that you see on the screen, that's my colleague Mickey Sperlick's study that had 81 women's narratives in it. And then the study that I did included just 15 interviews. But they were women who had both good experiences and bad experiences. So we know that having a positive birth, that succeeding at breastfeeding if the woman wants to breastfeed, feeling the emotions of motherhood and the bonding were powerful healing experiences for them and really made a difference. So what is the Survivor Mom's Companion? Basically, it addresses PTSD and maternal development in tandem. And it is for women who have a maltreatment history, and it is psychoeducation. So that's information, skills training, and emotional support at the same time. It does have 10 workbook modules, and the woman does the workbook for homework and then has a 30-minute tutoring session with the nurse or doula or health worker. But we have found over time that on average, women don't do all 10, they do about 7. And so we insist on the core 4, which is the overview, and it teaches the 3 target mechanisms of change: PTSD symptom management, emotion regulation. So that's both low mood and anger expression. There's specific stuff about not squeezing or shaking a baby. And then also interpersonal regulation. So how to read the baby's cues, but also how to read a midwife's cues, and how to repair a relationship that's had a rupture in it. And the other modules are more problem-oriented. They're about breastfeeding, getting your needs met, building your social support, and then there is also a module on post-traumatic growth. And the most intense module for people, where they have the highest scores on distress, is module 7, which is about coping with families of origin and making decisions about who can be with the baby unsupervised and who cannot. And that just seems to be an extremely emotional module for people to work on, but very important. It's the explicit abuse prevention part of the program. And we have exactly parallel pregnancy and early parenting versions. Our Aussie collaborators, Heather Rowe and Jane Fisher, co-wrote with us the early parenting version. And that version also touches upon the possibility that the birth experience was traumatic and how to work through that. So basically, it is a state of the science intervention. It's exactly like the psychoeducation that would be provided to women maltreatment survivors ahead of facing a psychotherapy. So it has the same target mechanisms as STARE and dialectical behavioral therapy. So it's built on the same theory of change, but where the triggers would be their psychotherapy processing the old trauma. And for survivor moms, the triggers are prenatal care, pregnancy, impending birth, and impending parenting. So it's just a slightly different form of preparation. And people have always asked us, why don't we just put this out on the internet? And we said, no, we won't do that, because trauma happens in relationship and it has to heal in relationship. So the tutor is actually vitally important. I'm going to skip this information. This is just answering, is it a promising intervention? Does it work? And I would say that the results are very encouraging, both in the pilot that we did in Michigan, where the interveners were social workers, and in the Champion project that we did in Buffalo, where the interveners were lay women. They were outreach workers who had usually less than high school education. They usually had done the general education diploma, which means that you dropped out of high school, but then you went back and you did the paperwork and you took the exam. So they were very well matched with the women that they were serving. And it was also a benefit that they were Spanish speaking. So the materials are still in English. We haven't been able to afford to translate them, but tutors who speak Spanish can have the conversations in tutoring in Spanish with the women. So I won't read this slide to you, but basically the evaluations have also been highly favorable, both by the women and by the tutors. So the women say that they learn a lot, they feel hope from this, that they had trust and got a lot more information out of their tutor than they would have gotten out of their obstetrician or midwife. And that some chapters were triggering and difficult to deal with, but they felt better afterwards. So I think that's really important. We measure distress 3 times across a session, homework at the beginning and at the end. And the thing that we find is that they do have emotional engagement, but then they recuperate by the end of the session and they're able to go on with their days. And basically, this quote that's in bold is, "This was the most helpful thing I did during pregnancy. It was a big difference, particularly the vignettes, and it was a bigger difference than I expected." So getting to talk about this a little bit during pregnancy, does seem to make a difference. The tutors like it. They feel that the training gives them confidence and an understanding of how to implement, and that they have people in mind by the time they've gone through the training, clients they've taken care of or are taking care of now, who they think would benefit. Another interesting thing about it is that we have had lots of support along the way, not from the federal government, but from NSPCC in the UK and from Blackpool Better Start, which is funded by the big lottery, from our schools, from the insurance industry, actually, because all of these folks are stakeholders in something that we deal with. So they either say that the cycle of abuse is an intransigent social problem, or that SMC can help improve quality and equitable access to perinatal mental health care. It's child abuse prevention, it improves utilization of maternity care, and it promotes trauma recovery. So we really have had quite a variety of funders. The other thing that's happening in the US now that may begin to happen where you are is that originally there was just one government organization that cared about trauma-informed care, and that was SAMHSA, which deals with mental health and substance abuse services across the country. But since 2019, there are now 27 federal agencies that are taking on the mandate to provide trauma-informed care. And I know that these acronyms won't mean anything to you, but CDC is probably familiar from COVID, the Centers for Disease Prevention and Control, and they are all about child abuse prevention. Medicaid and Medicare payers, health quality organizations, the National Institutes of Health for research organizations. So there are many stakeholders in the government who are going to probably begin to promote this, and then after promotion comes mandate at a certain point if effectiveness is shown. So I think that if that happens in Europe, soon, that will open doors to funding and to doing logistics. So I really strongly think that psychoeducation for PTSD following childbirth could be a very good way to go. And I'm hoping that some development is happening and testing is happening there that will make its way into the literature soon. So basically it could involve also the other levels, including activism. I think women who've had a traumatic birth and who have the part of PTSD that manifests as anger, that they would be happy to join in a movement for increasing respectful birth, physiologic birth choices, and holding people accountable for the nature of the care that they give. So one of the things we know with the survivor moms' postpartum outcomes is that it was not obstetric emergency that made them symptomatic in the aftermath. It was more likely the re-traumatization from not being well cared for and being disrespected in labor. An abuse survivor knows when she's been disrespected, and she's not expecting that from caregivers. So manifest anger is something that could be harnessed into activism in the end. In a nutshell, our lessons learned are to go for sustainability from the get-go, which means that having specialist treatment that's effective and evidence-based is important, but moving down the pyramid to having frontline things that can be delivered by frontline workers is also very important. Short is sweet. We made 10 modules, but really, 4 would have probably done the trick, and optional ones after that. Virtual does work. We kept doing this during the pandemic, and we changed our training to being Zoom-based training. So sometimes if people think the numbers in their country are low, or their population is distributed, or it's like a rural population, or low resource women who don't have capacity to travel to a site. We originally developed this for telephone, and certainly we have Zoom now, so virtual is a real possibility. Full manualization is really important. It facilitates good outcomes by fidelity, and it facilitates research on the outcomes, but also in the United States, if it's not fully manualized, it can't be reimbursed by insurance. So it's very important. Paraprofessionals do a great job. One rule of thumb, and I could not find a reference for this, but I remember it very strongly because it's absolutely true as it's playing out for us, is that the less education that your implementer has or your intervener has, the more manualization that is required and the more supervision at the beginning, not necessarily over time, but when the team is just starting out. And also to go ahead and do disruptive change, toss a targeted program into the middle and build out the universal and the specialist linkages. So I could quit there, but I'm going to just run past 2 or 3 more slides to put things on your radar screen, just in case they're not on your radar screen. I know that many of you are in practice, you're administrators, and so as a researcher, I do sometimes have the privilege of just reading things. And one of the things that came across my desk recently, I think is really important, which is that we all know about the ACEs, the Adverse Childhood Events, but Veronique Mead is beginning to promote the ABEs, the Adverse Babyhood Experiences, and these include many birth practices and perinatal outcomes. So I have the website here, but basically if you Google Adverse Babyhood Experiences, you will see her list and description of what those are. And they're working on creating an Adverse Babyhood Experiences score, just like an ACE score. So there's that. The other things that has kind of rocked my world in the last 2 years is that in the United States, where trauma has really been considered within the domains of psychology, it has now pierced our consciousness that trauma is also a human rights violation in many cases. And trauma and human rights are beginning to come together in the ways that we teach about it. And it's doing exciting things about helping us consider different interventions. And it's a very strong paradigm shift that's switching to holding perpetrators accountable rather than helping victims recover. And those two things aren't either or, they go together. So the focus on restorative justice processes and affiliations and activism are coming into play as well. And this is really important because once we do recognize the extent of trauma in our populations, it's going to overwhelm the capacity for individual psychotherapy as a treatment modality. We're going to have to invent some other things. So this book I put up there, it's written by colleagues from my collaborator, Mickey Sperlick's School of Social Work. And I used it for the first time in a course in the fall, and the students just gobbled it up. It blew their minds. So I highly recommend, if you haven't been able to use a human rights framework, basically looking at what happens to women and what happens to children as not only, individual wrongs, but as human rights violations against groups. So it's very powerful. And I just want to leave you with the thought that post-traumatic repair in relationships and in terms of recovery and post-traumatic growth are really feasible goals during the 4 semesters of the childbearing year. So we have a ways to go yet, but I see progress.
Great.
Yeah, I'm sorry for running over, but I
no, it's actually fine, Julia, and thank you so much. That was just amazing. I think I've more notes and questions written than than solutions or suggestions. So, and we have this opportunity now to ask questions, and it links into what we had put aside as a potential sort of networking session anyway. So it's great. We're not under pressure, and of course we'll give you 5 minutes to get a cup of coffee if you need to.
It's okay, my coffee's right here.
Great. Okay. So very happy to open the floor to questions. So I'm not sure, do people want to raise their hands, or do you want to put it in the chat and I'll bring them forward, or how would you like to do it?
If you guys use the raise hand and reactions, it helps me because it bumps you up to the top of my screen. Yeah. So I can see you.
That's great. Okay, well, Julia, I might start because I'm just being cheeky, but I'm wondering how the insurance provider industry came to the point of funding anything like this that isn't, sort of, we've got very limited bits that you can get funding depending on your policy here, but it tends to be more around enduring mental health rather than being sort of pregnancy related. It's probably one of the areas where the benefits are least and the shortfall of what you've come up with yourself.
Yes. So that is a really tough nut that we are just going to be able to crack, I'm hoping, in the next year. Of course, our health system is extremely fragmented, and home visitors get paid differently than midwives and so forth. But we have done a few good things. We have made it fully manualized. So right now, it's being implemented in our hospital here in Ann Arbor by midwives, and they're going to submit for billing because they can do counseling of a victim of child abuse, and they can do psychoeducation and charge for it. So they're going to do that. The midwives do not want to do this over time because it's not cost effective. But once they've gotten it paid for, then they can write an order for a nurse to do it. And because it's fully manualized, a nurse can be reimbursed. So that would be the next step. We need to succeed with a midwife doing it, then a midwife ordering it for a nurse to do it. And home visitors, those programs are usually paid through government block grants. So they wouldn't need to charge for it in particular. What they would do is just change their home visit from talking about, like, let's say infant development in general, to doing survivor moms for 30 minutes of the 1 hour visit. So it would fit into their paradigm. So it has been really challenging, but once the other thing that can happen is that in their assessment, if they begin to assess for ACEs or child maltreatment history, then they've identified a need to respond to that. There's like a one-to-one in our psychosocial assessments between finding a need and addressing a need. So if they add ACEs scores to their assessment or child maltreatment history to their assessment, then they can use survivor moms to address that unmet need. So it's a process.
Yeah, because a lot of what we hear here is, oh, we're prioritizing other acute services, and when we're asking it to come from central funding to be free at the point of use, I think we reach some challenges.
Yes,
So,
exactly.
yeah.
No, it's definitely a work in progress. And you know, an RCT would really help it be evidence-based and catch on as well. But we've submitted 7 federal grants and it has not funded. So at this point, we're going for implementation hybrid studies where we're going to gather data on the clients, because an assessment at intake is part of it. And then an assessment at discharge is part of it. And that's pre-test, post-test. We have implementation notes all along the way. We know who got referrals. We know who used referrals. And so, you know, we're just going to essentially collect de-identified data from multiple sites. But it's not good science. There's no control group. So we need, maybe, you know, Europeans would be able to have a successful RCT of this. I'm not sure.
Yeah. It's always coming down to getting that empirical support, isn't it, to validate, which is, yeah. I see there's another comment there, but I'm not sure if people are putting their hands up, but there's a comment there from Katharina. This could also be a tool for peer-to-peer parents organizations. Maybe you would be able to speak to that, Julia?
Yeah, so I absolutely positively think so, in which case the costs of it would be very, very low in any case. I don't have evidence yet. We just finished training parent advocates in Chicago. They're doing their first training cases starting next week. So we will have some outcomes. For us, whenever we go from the intended interveners down to the next level of education background, we like to run a project to verify that the safety is good and that there are no adverse events. And that has absolutely been the case with doulas and community health workers who were employees. And now we will check with what we're calling near peers. So experienced parents, they turn out to all be survivors. That wasn't a requirement, but of course it's salient to them. So that's wonderful. And they will have supervision for it. So it's not yet, you know, completely free flowing. They are connected to an organization that can support them as tutors. But yeah, that would be very exciting. Also, group prenatal care. You know, in the United States, a lot of groups are doing centering and meeting with people as a group. Yeah. Olga, I see your hand. And then Julia, I see you too.
Yeah. Was that my
Olga,
hand
you're muted.
to take down?
Yeah.
Julia.
First of all, I would like to thank you, because while you were talking, it was as if there was someone caressing my heart. So thank you for that. Thank you for bringing this to this group, because I've been working in the field for 25 years now. I'm very well aware of what you are talking or not talking, but implying. And I would very much like to ask you, from your experience, what is it that creates so much resistance in our field as professionals to see what is apparent, but no one wants to touch or embrace and bring to the surface?
Mm-hmm. You know, Olga, I think that's a really good question, and we could have a really rich discussion about that. But my sense is that there are many healthcare providers who have some trauma too, if not from childhood, from their medical education, which is a form of hazing, I think, in many places. It's very noxious and tough on the person. And also, obstetricians are surgeons, and I think that they self-select to that. But what we depend on them for is to be able to do surgery in an emergency. It's not the same personality as the person who could have a meaningful conversation with someone about why they're anxious or what happened to them, what do they need. So I think it's a matter of also reaching the providers and helping them process any trauma that they have. But also systems change. In the United States, midwives and obstetricians get 6 minutes for a prenatal visit, 6 minutes. They are desperately afraid of opening a can of worms that they don't have any time to deal with. And so I think there's resistance there. So I think we need to trauma inform the system where PTSD becomes a diagnosis like gestational diabetes or like preeclampsia that deserves extra visits and perhaps extra caregivers. And the extra caregiver could be a doula or a parent volunteer, but the person may still need something. And we just have to get the system to be able to recognize this as a real thing and then see that interventions could actually get us to better outcomes. And I think it's still a long process.
Can we perhaps, in this group, which has now listened to this, can we just open up and embrace this as a possibility for the next 2 years to go for this action, to do something, taking into account that this might be a possibility to look at?
We can talk about that at future meetings, Olga. Yeah.
Yeah. I would be thrilled. Absolutely. I would be thrilled. So and you know, I think that you're capable of implementation and research projects. And so a lot could be accomplished. We also are going to the level of producing education for the providers, which I think is very important as well.
Thank you.
Julia, you've had your hand up for a while.
Oh, sorry, my microphone. Thank you for the very interesting presentation, Julia. It was great to hear this aspect really put into the focus for this action, for this meeting. My question goes in the direction that you already have elaborated on. I'm wondering about the midwives. Could you describe a little more in detail, what do you think, what training do they need? Because if we were to implement that intervention as described, like the Survivor Mom's Guide, like, you know, they have in Germany, I can say, for example, the midwives have very different levels of education in regards to maternal mental health and trauma. So what do you think do they need, or what do you offer on? I've seen there's training programs on your on the website for that Survivor Mom's Guide, and could you talk about this?
Sure. I don't think they need a whole lot. I think that midwives care about interpersonal practice, and they've probably seen it all. They just haven't necessarily known what they're looking at or how to respond. So some of the things that we hope to try in the near future is to provide education with, first of all, a journal club to help people's knowledge base, but also to give them the core 4. So to work with them to do the same 4 modules that the women do, so that they're learning exactly what their clients are learning in terms of examples and vocabulary and getting to problem solve for clients. They're seeing it from the client perspective. And that essentially they would do that as though it were a journal club. They would do it together and then get to talk about cases that they've had and so forth. And we're doing that because the people who've done it so far thought it was really fun. And, you know, it's written at the 4th grade level, so even a midwife can read it, right? And that they enjoyed seeing what their clients were going to be learning, and it got them ready to meet clients on the ground about it and have conversations. So I don't think that they need something super intense. I think that basic things would really help them, especially when there is the program to offer then, because they can say, well, let's talk about what your triggers are, but also why don't you take the Survivor Moms course and see how that goes. I also am working on creating a course that's more sophisticated, that'll be available online for people who do have a very strong interest and want to gain some real sophistication around this, but that doesn't have to be everybody.
Thank you.
Anja?
Yeah, Julia, sorry. Thank you very much for your wonderful, wonderfully interesting talk, I should say. I was just wondering if you suddenly had the money to run a large RCT, as you have wanted to do for a long time. I was just keen to know what will be your primary outcome. And I tell you why I'm asking you, because it is such a complex issue, isn't it? And I was sort of thinking whilst you were talking, wow, you know, how would we be able to actually measure the effect of such an intervention, which is really a complex intervention. And you know, I'm just aware of other sort of interventions. I don't know if you saw the publication by Pauline Slade and colleagues who did a trial on, I think it's called the STRAW trial, who looked at a psychoeducational intervention immediately after childbirth to try and prevent PTSD, and they didn't show any effect of this. And this was also an intervention carried out by midwives, which of course is a different population and a different focus from what you're talking about. But I was just keen to hear what you would reply in terms of how would you define actually your primary outcome?
Yeah.
You know, what would be your main focus of your intervention if you had to test the effects of it?
So in all of the RCTs that we proposed that didn't fund, the primary outcome is management of PTSD symptoms. So we would expect a drop in symptoms. And I can show you the slide where in fact we do get that at a medium effect size. Yeah. So our theory of change is management of PTSD symptoms despite the presence of triggers. Yeah. Emotion regulation, interpersonal regulation. So we also measure those things. And then in the last one that we proposed, which was a large grant, so it was a $5 million instead of, NIH usually caps it at $2.5 million. But we went on to measure infant outcomes in that one, as well as maternal mental health. So we were looking at the dyadic relationship with a nursing measure called, I want to say the NAST. I don't remember what it stands for, but it's observational. A home visitor codes the interaction. And we would have been looking at infant developmental milestones and potentially even self-regulation like infant cortisol, infant heart rate variability, because in moms who are not doing well, you know, one way to see a PTSD reaction is that it's dysregulation. And when we look at the infants, they have similar dysregulations. It's almost like they are mirroring or pairing each other. So those are the types of things I would look at.
And so would you then see it more as an approach to help women manage their symptoms, or would you see it also, you know, would you also expect to some extent some curative, you know, effect at the end of the day? What would be the sort of,
we expected just to manage the symptoms, but in fact, we saw symptom reduction. So the way I view that is they're succeeding at managing their symptoms, but it does not in any way process their old trauma. It is actually a present and future focused intervention. There is no need for them ever even to disclose what happened to them when they talk with their tutor. So I don't think that it's achieving what prolonged exposure, EMDR, or CBT would achieve. But let me show you guys real quickly, going back to the slideshow. I can show you the slide. that shows the PTSD symptom decline. Okay, let me just do screen share here. Okay, can you see this? Okay,
Yes.
so basically remembering that SMC is targeted intervention. So we just ask them if they want to do it. And we do assess their PTSD at baseline, but they don't have to have PTSD to do it. So what we did for this analysis was that we just divided them into two groups, the 9 who did fully meet diagnostic criteria at the beginning, and the 16 who just had some PTSD at the beginning. And we used a symptom measure that has frequency and severity. And so after module 2, module 4, module 6, and module 8, we rescored their PTSD. And 35 is the diagnostic cut point on this measure for probable PTSD. So you can see that those who met criteria actually fell below the diagnostic level by the end of module 2. So they had already learned something by the end of module 2. And that these people also had lower symptom levels, even though they were below the threshold to begin with. And these were statistically significant, even though this is a very small pilot. When we repeated this in Buffalo with the outreach workers, it's not in graph form, but down here you can see that the effect size of the change in PT. So this group started out on a different PTSD measure, which is for DSM-5 now, in the severe range. The reach to this group in Buffalo, it was a much more low resource setting. And so they were in the severe range to begin with. They also had moderate depression on average. The change in PTSD score was medium effect size, and same for depression and same for interpersonal reactivity, small effect size for anger expression. So basically, they're getting effects that are similar, almost as good as a psychotherapy, which is kind of beyond our expectations, but it also points to how unmet their needs are, that, you know, even just learning what it is and how to manage it, having some metaphors to think through or tricks to try, was helpful to them.
Thank you. And I'm sure there are lots of mechanisms at play, right? I mean, one could think about, you talked about emotional regulation. I suppose one could think also about cognitive mechanisms in terms of reappraisal and, you know, change of meaning. Think about empowerment. I mean, there's so many different mechanisms at play, one would imagine, right? Both linked to the individual as well as to the interaction with the care providers, as well as to the setting as such, you know, that is sort of meeting perhaps more the needs of.
And I think there are probably so many non-specific benefits in terms of finding out you're not the only one, finding out that you have symptoms, not you know, a horrible personality. Hopefulness. Our last module is on post-traumatic growth, and sometimes, you know, the women and the tutor are both crying at the end because the woman says, "This has given me so much hope. I feel like I can stop the cycles with me." And so that is like, gives me goosebumps, you know, when I hear those stories. But hope is really important when you're going into, you know, having your first baby. It's very important. So speaking of this, I'm seeing in some of the comments that people are like, you know, do you want to do a study on this and stuff? It's like, I would love to. And also, we've written the grants like 7 times. So if you want to write a grant, you let me know. I will give you a lot of text to work with, you know, so.
I have a funny feeling you'll be inundated, Julia, and being invited to all sorts of grant writing meetings to help hone down and look at what the potential possibilities are, you know, whether it's EU or whether there is something that I know your national funding agency used to do tripartite ones with Ireland and Northern Ireland, but I'm not sure what schemes you have now. So I would imagine there'll be plenty of opportunities, and people will be mad keen to develop.
Yeah, well, I would love that. And we also will need to do translations of things, but I think that our materials are in quite good shape to do that now. We have had Spanish translation in the past, although that was a few versions ago. And I'm French speaking. I would love to do a French translation at some point. So yeah, it will be fun.
And just to say a couple of more messages, I'm not sure, Alison, who's one of our early career investigators, Alison, do you want to tell Julia a little bit about the new work that's happening in your area?
Yeah, hi Julia, great to meet you, and thank you for a fantastic presentation. I was, like, I think many of us were totally gripped throughout. I just wanted to say it's really resonating with the work that I'm doing at the hospital where I work at the moment in the UK. We're currently setting up a birth trauma service that is prominently focusing on a joint integrated maternity and psychology service that's going to have maternal mental health midwife sat within that structure for referring on to a psychologist that will sit within maternity services. The frustration that I'm having a little bit at the moment is that we are only focusing on women who have birth trauma rather than the sort of dissociative trauma that you're talking about that women bring antenatally. And I keep saying we need to be looking at these, you know, talking about how we can provide this care for these women, but we're just in our pilot year at the moment, so it's still just setting things up, but certainly lots of things to be thinking about. And something I definitely want to look more into is the net therapy. I think that would be something that our midwives could really benefit from. So I'm thinking about what sort of training. I'm doing some multidisciplinary training in September for our team, and thinking about where we can utilize some of the things that you've talked about today.
I know that Andrea Spiridu is here, and she's a net trainer and proponent. So hopefully you guys know each other already and can connect around that. She's the person that I've worked with on thinking through those ideas. And, you know, Alison, one of the things, hi, Andrea. One of the things I would say about the opportunity that you have is, you know, like, go for it 100% within the constraints, and then see if you can subvert a little bit, or do what I call, you know, guerrilla research, which is that, you know, when you're working with women about the birth trauma, see if your instruments can be tweaked to ask, you know, are the symptoms you're having from the birth or something else? Because women can answer that question, and they may say, I don't know, because they don't want to disclose, or it may honestly be murky if it's from childhood. But at least you can begin to see what proportion of the women you're working with, this is not a brand new trauma, that it's connected to something that they already had. And then still, you know, they need what you have to offer. And the other form of subversion is to say, you know, do you want to talk about, you know, any of the stuff from the past that might be affecting this right now? I don't think you necessarily have to change a whole protocol to be able to at least open that conversation, and then write really good notes, you know, so that you can go on to the next grant saying that an ad hoc finding was really that this wasn't the first trauma for a lot of these folks, and we need to just enrich what we do a little bit.
Yeah, I think as a midwife, that's what I am, is that fear, I suppose, of opening up those wounds and not being a counsellor or trained in that specific area to talk to women about previous trauma. And I think this is where the trauma-informed care element comes in, and sort of helping sit at that universal level, that bottom part of the pyramid that you talked about, and how midwives can have a bit more confidence or the sort of skills to tap into that, really.
Yeah. And, you know, I don't want to encourage anything that in your judgment could cause harm. But I do strengthen you to consider the disruptive change of also creating something frontline that's available. You know, if you implement your intervention and you find that, you know, 4 out of the first 6 women are symptomatic, but it's both the birth and something else, you know, that gives you a chance to not stop your trial, but to go back to your research group and say, we have to advocate for something more here, because even though the data are thin, there's data that dovetails with the literature that would say that, you know, we need to address this also, and how can we do that?
Excellent, thank you.
So before we exhaust Julia altogether, can I just ask if there's any more? Susan, I see your hand is up there. Thank you, Susan.
Hi there, Julia. Thank you for that amazing talk. Really, so much information and really, really interesting. I was particularly interested in what you were saying about the salient trauma history. And the Survivor Mums program seems to be very much developed around maltreatment or a history of sexual trauma, perhaps. And I wondered about the other salient traumas that you mentioned, of previous pregnancy loss, medical trauma, or previous traumatic birth, and whether the Survivor Mums program could be used with that group, or whether that would require some modification or something different.
Great question. I do think that SMC is really for people who identify that they had some abuse or neglect or sexual trauma prior to pregnancy. So if, for example, they had let's say they'd had a miscarriage before, and so throughout the pregnancy they're concerned about the risk of losing this pregnancy, I just don't think that Survivor Moms is going to affect that anxiety. I think they would need a different program. But I think that, you know, that 1 out of 5 women who have this background also maybe had those other things happen as well. And so it's possible that the 2 types of programming could go together. But I just think that we still need to develop good frontline programs for perinatal loss, although there are more than for maltreatment history. And similarly, we have since used, we intended SMC for first-time moms, but it has been used by women who are having like a 3rd or 4th baby. And what they said was that they wish they'd had it with the first one, but they're still learning stuff, so it's good for them. But we just, in all my research, I have only collected really good data with women for whom it was the first birth. So I don't know really how birth trauma would play out for them in the early parenting version. And I think it would be great for somebody to test that. We have more people who are testing the pregnancy version and working with pregnant women, but we would love to have people who would take on the postnatal version and see how that worked, and even examine the module that touches on telling your birth story and if you had a traumatic birth, and see what you think, because our mindset was really that this was a survivor and anything could have happened during her birth. It wasn't set toward the birth trauma per se.
Great, thank you.
Thank you for inviting me, by the way.
Oh, I'm so pleased you came. Amazing, amazing talk.
Julia, can I ask, in those first-time moms, do they all give birth to a single fetus?
Yes, I think so.
Yeah, I suppose I'm particularly interested in where there's a multiple pregnancy and different outcomes for each infant, if you know what I mean. Yeah, so I suppose it sort of fits a little bit with your NICU and stillbirth mums in some ways, but yet there's a live child as well, if that makes any sense. I'm wondering if you would work in that area. That's great.
I mean, the way that we think of SMC is that it's a tool, but the woman still needs the right tutor with her. And so, I mean, another way to handle it would be, instead of a frontline worker as the tutor, for someone who had a complicated case, to actually give them a mental health provider who would work on the book with them, or give them a perinatal nurse and someone who knew therapeutic communication and anticipatory guidance for people who have, you know, challenges that go beyond the manualized intervention.
Yeah. And I know that we had significant issues here in Ireland where it became a standard of practice that women would be asked about intimate partner violence. And it took a long time for it to be implemented on the basis that, well, what do we do in response? Now it's kind of gone the other way, and it came to a head actually during the pandemic, where we were asking the question, we got used to asking the question, but there was no space available in any refuges after we had asked. And so I'm kind of wondering about not just the fear of, is there a service, but at what point, if you ask and you get a response that you're concerned about, might it overwhelm a service that isn't particularly well resourced? And I'm wondering, did you come across any of that in terms of any kind of ethical or service provider blocks, you know, how do we anticipate what this is going to do?
Yeah, so actually we did run across that in Blackpool, England, which was a champion site for taking on survivor moms through the Center for Early Childhood Development, which is funded by the Big Lottery and works in collaboration with NSPCC. And it was social workers who were implementing there. And what ended up happening fairly early on was that it became clear that they were recruiting through children's centers in the community and offering it in home visits, and that they could not get a referral to mental health for the clients. Like, they could just get them to the GP, which, you know, wasn't very useful because the GP didn't have anything to offer either. And so they actually stopped the project for a little while. And we went back to England. You know, we had a contract to work with them over several years, and we went back to England, and instead of watching over the team delivering it, we participated in workforce development opportunities. So Elsa Montgomery came, Julie Taylor. So people who had expertise in this joined with Mickey and I. We went to the Blackpool Winter Garden, the big auditorium, and we led a panel that we saw a bit of a movie, and then we led a panel discussion, and the police chief was there, and we were there, and some specialist midwife was there. And we did the work of trying to help Blackpool become a little bit trauma informed. And then the British there in your group may know that a call went out from the National Health Service to write clinical guidelines about trauma-informed care for maternity care. And we engaged with Blackpool in putting in a bid for that, and that was accepted. And I was not able to take part in that, but Mickey Spurlick did work on that. And so those recommendations should be coming out any day now. I think they may actually already just be out. So essentially, it's trying to build the system. And what has happened is that the social workers did like the intervention very, very much. So what they would do is, when they thought a woman would benefit and she was well plugged into the healthcare system, and they thought she was pretty stable and probably not going to need a referral, they actually have gone ahead and continued to offer it. So even though they stopped after about a dozen women, actually about 72 women have done the program. It's totally like not even official right now. They're just pulling it out when they think that it's safe to do it without the system being entirely in place. But, you know, the specialist midwives, they should be connecting better to the NHS, and they should be pulling the specialist midwives in, or community midwives who have continuity of care. You know, I'm not expert on the health system there, but I know that that's what they're trying to do. That their conclusion from the very beginning was, oh, we just did disruptive change. We threw this frontline intervention in, and we don't have tier 3. Yeah. We got to get tier 3.
Yeah. Yeah, my head is spinning. Sorry, Julia. That's why I'm being so inarticulate at all of the possibilities. You know, if there's low-hanging fruit, how can we get it and get it quickly to build further on? So can I ask anyone else any last questions, or I will say thank you to Julia. Any last questions?
Sorry, do you mind if I ask a question?
Yes, please,
Julia,
answer. Go ahead. While we
if you're
have
still
the
happy to listen to
opportunity.
another question.
Oh, yeah.
You know, I love your model of trauma-informed care, and I suppose the way I understood it was also that there is this whole aspect of sort of staff themselves engaging in more reflection about their own practice, and sort of staff being, you know, more supported by their colleagues, but also by, you know, by the hierarchy and so on. And I just wondered, to what extent have you been able to also look at that in a little bit more detail? Maybe that hasn't been a priority, but I just wondered, do you have any data yet on sort of, you know, to what extent actually has care improved from an objective point of view, if we want to put it like that, because of this approach of trauma-informed care?
Yeah, that's a great question, and I really thank you for asking it. In our first pilot in Michigan, it was done at our university hospital and also out in a rural part of the state. And for the women who did it at our hospital, we often, I shouldn't say often, several times we got phone calls from our midwife colleagues after they attended a birth, and they were just so excited that they wanted to tell us the story. And it's one of the reasons that we kept with the name Survivor Moms, Survivor Moms Companion, because our Aussie friends told us, like, that is not going to fly. And in fact, in Australia, we just had to call it something else. But what I will never forget, the phone call. I walked into my office and, you know, the phone's ringing and it's 7:30 in the morning. Like, who's calling at 7:30 in the morning? A midwife who's going off duty. And she said, "Oh, I'm so glad to reach you, Jules, because I attended a Survivor Mom last night and it was so amazing," and blah, blah, blah. And so she didn't call her, you know, that difficult patient or that crazy controlling cow, you know. She said, you know, that Survivor Mom, and that they had been able to navigate the triggers and what the woman had needed. And they bonded because the woman was able to say, "You're doing such a great job for me. This is so much what I hoped for," you know. And then it was a smooth and terrific birth, you know. And so they got to have a feeling of accomplishment because they were able to converse with the woman. And that's why we created it as an intervention for women and not for the staff, because we feel like we can't ever control what the staff are going to do. And also at academic health centers, it's trainees all the time, just turning over, you know. So we thought if we empowered the woman, that providers do want to respond to their clients. They do want to do a good job. And so we have had several instances like that where people have called to let us know that they thought that they had a more successful birth and that they didn't even know that they had survivor clients, because the women did not have to go through their provider to join the project. So they were like, "I didn't even know I had survivor clients." I want to tell them, yeah, every person that you're having trouble getting along with is one of the 1 in 5, right? Every one of them that gets so angry she wants to sue you is one of the 1 in 5. You have a lot of survivor clients, you just don't know it yet. So the providers do also find that it's very helpful.
Yes, and I guess as you say, I mean, you know, we know the negative spiral of interaction between, you know, women and healthcare providers, but of course it can also hopefully turn into this positive spiral where, you know, more and more positive interactions are happening, and so, you know, the quality of care also improves from an objective point of view. And yeah, I think that would be really fantastic to look into as well, wouldn't it? In some way to sort of see what happens there for the care providers. And you know, I'm just aware of all the research that's out there showing actually how you know, how much trauma and burnout and so on we find in healthcare providers in, you know, in the perinatal period, and to some extent one wonders, you know, what happens when these care providers then interact with women and families who themselves are traumatized as well, you know, and one can imagine that sort of lots of vicious circles of interactions happen quite quickly. So it would be really interesting, I think, to see also to what extent this can be turned around into a sort of positive interaction. And you know, one could imagine that as you illustrated, that for care providers that's more satisfying, obviously, if they have the sense that, you know, they've done a great job and it's very satisfying for them, and one can imagine that will have positive knock-on effects also for, you know, future care provision.
Yeah, and you know, I could tell you like one or two more instances. In Indiana right now, also in the Midwest, we have an early adopter of SMC who just moved from Chicago to a different university. She's a clinical psychologist, and she's been dealing with, you know, women's health, some perinatal therapy. But now her job is to turn the OB department into a trauma-informed department and to link with psychiatry there. And one of the first things that she's going to be doing is leading a journal club with some guides that we have developed and a book group for the OB residents. And I think that what happens when you start is you get this relationship between a mental health professional who is sophisticated in their understanding, but wants to be friends with these docs, and the docs get to know you as a real person and a colleague. And then the possibility for consultation for difficult cases comes up, and people get ever more sophisticated. It's not like we stop making mistakes, but we debrief from them and we think of what we could have done differently, and then we do better. And also then when the docs have a really harrowing experience, they also have someone that they can reach out to say, I'm traumatized about this, and, you know, just get some support outside of the medical community, because it's not always supported to share that. You know, those surgeons are supposed to be tough, right? Yeah. So that relationship between the therapist and the OB team is very important. And, you know, honestly, they feel uplifted when they do a good job for a provider or for a client. I remember a story, and that's why I talk also about these days, I don't say so much about post-traumatic stress recovery, because that makes it sound like it's an individual a lot of the time. I talk about post-traumatic stress repair, because, you know, it needs to be fixed, but often it's a relationship issue. And we talk about repair in psychotherapy relationships or in mother-infant dyadic relationships. And so there was a story about an obstetrician who in an emergency had to cut an episiotomy. And that woman had specifically said she did not want to be cut. And so that person realized that they had to do it in the emergency. They felt it was their best judgment. There was no time to talk about it or ask permission. And yet they knew that they had, you know, basically like, you know, done a bad thing. It was a problem. And they were able to go to the client's room and talk about it afterwards and say, I'm so sorry. And that woman's birth story went from, you know, being violated to understanding that there had been an emergency and that this person did the best they could for her, and that there had been no time to talk about it, but they came back afterwards and there was repair there. And her birth story was less distorted and more complete after that happened. And the provider got to feel better too, because they had the courage to go to the bedside and have that, I'm sorry I had to cut you, here's why, can we please talk about it, conversation. So it doesn't take a lot to make the staff more sophisticated and more willing. It's just they need to share case experiences, and they need to share their triumphs and build on them.
Thank you very much, Julia.
Great, Julia, thank you so much. I think we have taken 2 hours of your time.
Oh, it was my pleasure. And I should go now and let you all wrap up your conference. I hope that your 2 days together have been strengthening and productive. And I will download, let's take a minute, ignore me, to download the chat questions. And I gave Fiona the slides, and you know, I think the recording happened, but my email is on the slides, and I'm very happy to hear from anyone. If any of you are in practice and can't get articles or things, I'm happy to send you PDFs as well. So just,
that's fantastic, and I have no doubt that we'll be in touch again as we progress and, you know, think things through. And I think we're all in such a delightful spin now that we need a bit of processing time. But I've absolutely no doubt we'll be in touch with you again if you've no objection to that. We will be back, as
great. I would love it. Thank you very much.
So what I will do now, if everybody else is okay, I would just like to say thank you so much to Julia for being so generous with her time and for sharing so much with us. And it's lovely just to have such a positive perspective, not always a pathologizing orientation to everything. And as you say, not the bad person, the character flaws and all the rest of it, but, you know, this happened to me and I can be assisted and whatever. So just to say thank you to everybody as well, and I'm sure you're all keen to sign out. We're all in very different time zones. The one disadvantage of not being in the same room is we're not on the same time zone. So can I thank everybody, and just to say I'll see you all again soon. And it was again a pleasure to have 2 lovely days with all of you, and no doubt we'll be in touch again soon. So can I thank you all very much and bring our lovely 2-day meeting to a close. Thank you so much.